Today, she's here to discuss mathematical disease modeling, leveraging data and simulations. Sheetal, thank you so much for giving us your time and your expertise. I'm going to hand over straight away to you, and please have a wonderful session, everybody.
Thanks so much, Nicola, and greetings, everyone. Thank you for hosting me at your H3G webinar series. I'm delighted to be here today, and I do hope that you engage with the material that we're presenting today and enjoy the session. So I'm just about to put my slides onto slide mode, and we can get going. There we go. Nicola, is that all good?
Yes, that's perfect.
Perfect. Thank you. So thanks, everybody. So I will be presenting today, as Nicola mentioned, on the field of study that we are engaged with on a daily basis, and that is mathematical disease modeling. And it's really a study of how we can leverage data and computer simulation in order to help make better decisions and to support operational needs to enable better health policy and health decision making. So let me tell you a little bit first about MASHA, the Modeling Simulation Hub Africa, the research group that I lead at the University of Cape Town. So MASHA is a research group that focuses primarily on policy-relevant modeling of infectious diseases. And what we primarily work on are health policy related decisions and day-to-day management of decisions. And in order to be able to support this type of decision making, we have to be interdisciplinary. So in our unit, we have experts in mathematics, in computer science, biology, medicine, economics, finance, and public health. And even though I may be a disease modeler, it doesn't mean that I would work alone. It means that I need to work with experts in other fields and other disciplines, all of whom are related to managing health policy. And that's what you can see from this diagram here, that in order to generate models, it doesn't just take a mathematician, it takes a lot of data and a lot of understanding of an entire health system. So at MASHA, what we do is we model health conditions and diseases. In particular, we do a lot of work in malaria, as many of you do at H3D. We worked a lot in COVID-19, as Nicola mentioned, but many other vaccine-preventable diseases and vector-borne diseases. So we have completed work with hepatitis A, syphilis, diphtheria, tetanus, pertussis. We're currently engaged in some work with measles and rubella. I see hepatitis A is repeated there. But we're also doing some work in other non-disease related conditions, such as supporting policy to decrease maternal and neonatal mortality. So we are applying our trade or our craft of mathematical modeling to all things health related, so that we can provide modeled evidence in order to support better decision making. So you might ask, well, where are these skills really needed? At MASHA, we spend perhaps about 30 to 40% of our modeling effort in South Africa, being based at University of Cape Town, so supporting the South African Department of Health and related organizations. But otherwise, 60 to 70% of our time is spent in supporting LMICs on the African continent, but also all around the world. And our name is quite general. We seem to have co-opted this term called modeling. What kind of modeling are we really referring to? And here are some of the chief methods that we use at MASHA. So we spend a lot of time doing compartmental modeling, which is population level stock and flow type of process flow modeling. We do agent-based modeling. We do mathematical optimization, and this is particularly useful when it comes to decisions that are resource constrained or have a cost element to them. And more we find ourselves, as data becomes available, we are using a lot of data science and statistical methods too. And I'll demonstrate a little bit of all of these techniques that we have employed across our projects. So what I hoped to do today was to exemplify for you some of the benefits of mathematical modeling. Where have we used it in the past? And then I'll dwell on some of our current projects as well. And this is all to give you a flavor of how useful this tool of mathematical modeling is, and also how differently it can be applied. So I'm going to start off with an example from South Africa that was led by the Department of Health, in particular the unit for vector-borne diseases. And this was a study called the Investment Case for Malaria Elimination in South Africa. So I know many on the call will have some background of malaria, so all may be aware, or most may be aware, that there is a goal regionally, continentally, as well as globally to achieve malaria elimination by 2030. And that goal was set sometime around 2008 or so. And so South Africa had, at the time of this investment case in 2018, had aimed to eliminate malaria by 2023. But given certain shocks, climatic shocks, and other operational shocks that had occurred in 2017, the country fast realized, as many countries also had to realize, that they were off track to reach their goals. And so for South Africa, we embarked together on a study, the University of California, San Francisco, MASHA, and the Department of Health. We embarked together on a study to help us project a path to elimination and to estimate the cost of achieving that elimination. So it very much was a study about, how do we do this? How are we going to get there? How are we going to get to zero local cases or zero indigenous cases? And how much is it going to cost? Because as an elimination country, our malaria was funded from what we would call our domestic budget, which means the budgets that are funded by South African taxpayers. So it is not, let's say, an external organization like the Global Fund or the President's Malaria Initiative who would be supporting elimination efforts in South Africa. It was the South African government, and so on our national treasury. So we would have to make a case to national treasury to obtain further money to achieve malaria elimination. So the point of our study was to find different pathways to achieve elimination, look at how much they would cost, and then identify a gap in the funding and take that gap, and with the modeling evidence, go and demonstrate to the national treasury how you can plug, whether, how they can plug that gap, or how we can obtain funding from them in order to achieve these elimination goals. So it was a year-long study, and what we ended up doing was, we, being led by the government, MASHA had developed a data-informed epidemiological economic model. That means it was a model that captured the biology of malaria. How does malaria really work? How does it transmit? What are the vectors that are concerned? And how is it different? We have 3 endemic provinces in South Africa, and they did not all exhibit the same level of malaria elimination or malaria transmission. And so we had to model spatially what was the trends in malaria transmission in these 3 provinces and districts within the provinces. And then we had to use mathematical modeling to explore a number of strategies. That means asking what if questions. So we would have to ask questions like, what if we scaled up our current interventions? How much would it cost, and how many cases would it avert? How would it bring down our malaria burden? Would that get us to elimination? And as we explore these strategies with the Department of Health, as well as scientific experts all around the country, we fast realized that we would need to, in order to achieve elimination, we would need to also address the high level of imported cases that were of malaria that were being recorded in South Africa at the time. And so we developed another strategy to model that included doing what we call source reduction. And source reduction was about addressing the sources of malaria that were resulting in imported cases. And these sources were outside the country. And so with the detailed case source and vector control data that was available from the country, we mapped this out and modeled and costed out this particular strategy. And what we ended up being able to do was to demonstrate that this strategy of source reduction was going to be the only strategy that got us to malaria elimination and would prove to be beneficial in terms of cost as well. And we took this evidence, the Department of Health took this evidence to the National Treasury, and the Minister of Finance committed on the basis of mathematical modeling and the modeling results that were shown, they committed 319 million rands to support the malaria elimination drive that was to be taking place since then. And this investment case and the resultant actions of mobilizing funding based on modeling were praised by not just the South African government, but by the WHO as well. And what we see here at the bottom is that South Africa received an award from the WHO for its efforts in combating malaria. And what was cited was that such a solid investment case was developed, and then advocated to receive the funding through a conditional grant, so that the money could be reaching the provinces to expend and pay for these efforts towards achieving malaria elimination. Of course, COVID-19 happened so straight after this money was received, which means that all health interventions have been delayed a bit, but this conditional grant is still funding the malaria program at the moment, and that is a wonderful achievement from this investment case. So this was a very good example here, you see, of mathematical modeling being used to test out, to develop a model that represents the situation of malaria in a country, test out novel strategies, put a cost to them as well, and then reach out to ask for funding to implement those strategies, and then being successful at it. That's an example of how you can use modeling for advocacy or for future funding. And so these types of investment cases were very popular, not just in South Africa, but MASHA supported investment cases all around the world. And if you look at this, the names of these countries here, there's, over 25, 30 countries listed here, where we've got the 22 countries of the Asia Pacific, one of the first applications of the investment cases that were completed. And what you see in this image here were packages that were designed for each country to be a minimum cost package to achieve elimination by certain date. I think this was 2030 actually. So this was investment cases developed for all 22 countries of the Asia Pacific. We see a study that was conducted later on here, where this was in Melanesia and Timor-Leste, which were the countries of Solomon Islands, Vanuatu, Papua New Guinea, and Timor-Leste. So another set of investment cases that were done. There was an investment case done for Ghana, and that allowed us also to, Ghana is a high burden malaria country, and this was with the Ghanaian government and allowed us to estimate the path and cost of elimination based on Ghana's national strategic plan. There was another investment case that was done for South American countries, and your countries here were Brazil, French Guiana, Suriname, and Guyana. And this investment case took place around 2020, but also very much interested in how could these countries get to elimination, and how much would it cost, depending on whether this was through domestic resources or funded by the Global Fund. And so this investment, so MASHA became quite a presence globally in conducting and supporting these investment cases done on our continent, but also in LMICs all around the world. So those are some examples of using modeling to support investment. And I think, given what we are witnessing right now in terms of decreased funding availability for malaria commodities, and the world right now is unsure of the impact that this is going to be having on malaria cases and a resurgence of malaria in general, I think you can understand the value of doing investment cases like this, so that one can work out the costs of what future malaria intervention are going to look like, and help governments to plan accordingly. So the next, I'm going to shift gear now to a different type of modeling that was done, and this is now COVID-19 modeling. And I think many of us would like to maybe forget COVID-19. We lived through that and we're tired of it. But I think there were some lessons learned, and we should reflect on those when we can, so that we can be better the next time round. So some background here as to how modeling was used in COVID-19, and this is a particularly a South African example. And here, the Department of Health in March of 2020 formulated what was known as the South African COVID-19 Modeling Consortium. And this was a modeling consortium that was convened by the National Institute for Communicable Diseases in South Africa, and comprised 3 modeling groups who were coming together to generate models to support the South African Department, the National Department of Health, in planning for COVID-19 response. And so here we were operating in a very different time. With malaria modeling, you may be aware of this or not, but malaria models have been around for over the last 100 years. They were much simpler 100 years ago because there wasn't all that much data available, and they've gotten a lot more complex over time. But with COVID-19, it was completely new. When you were asked to model, as we were in March of 2020, there was very little known about COVID-19. In fact, what was known at the time, all we could observe from were the wave 1 that was passing through Europe at the time, and only a few cases had entered the African continent. And so we weren't sure how our populations would respond to the transmission, and whether our health systems, our hospitals, our clinics, and our health systems in general would cope with the burden of COVID-19. And so when we started off, we had to make very simple models. And you see here on the right, no, this is the left-hand side, sorry. On the left-hand side, you see what is a simple compartmental model. And this compartmental model, at the time, it was version 1 here, in March, was developed for 9 provinces, and it was taking into account that the population was basically entirely susceptible at the start of the epidemic, and that there was no inbuilt immunity from anyone. Everybody was susceptible, but there was the ability to have an asymptomatic infection or a symptomatic infection. And if you had a symptomatic infection, it could become severe. And if you were severe, you could end up in hospital, where you might have access to an ICU if needed, and where there would even be a ventilator that would be available to you at this in the ICU. And of course, there were outcomes we had to measure, because already there were records of people who were dying from lack of oxygen, and this severity of COVID-19 cases at ICU wards and in general wards at hospitals. And so we had a very simple model that was really just trying to understand the clinical symptoms of COVID and who was ending up in hospital. And we developed this for 9 provinces. But we fast realized that this epidemic was evolving, and every day we would get new updates on how the disease was, or the virus was behaving. I have not so fond memories of being woken up every day at 6 a.m. with some member of the Department of Health emailing me or texting me a new paper that had come out to say, have you included this new science into your model? So we were having to make updates almost on a daily basis. It was quite traumatic, but we also knew that decisions were being made on a daily basis. So we had to get our models to be updated as frequently as possible. But what it also meant was that because we had such a short turnover between when a request was made for an update on a model and when the results were needed, we couldn't develop overly complex models, because a complex model can take a long time to run, days even. But if we had to develop a model to provide results tomorrow, we couldn't really say, actually, our model is so complex that we can't give you anything, because these decisions are going to be made with or without you. So we as modelers had to come to our own decision to say that if we want to be useful, we need to get our models to run in as quick a time as possible to support the decision making window and so window time frame, I think is what I'm trying to say. So we had to make lots of iterations and also keep our model simple enough but also complex enough to answer the questions being posed to us about capacity and the number of ventilators and staffing and so on. Eventually, and several variants later, we had to make our models a lot more complex. So what you're seeing here on the right is a model that is far more complex than just this model here, which was replicated 9 times for 9 provinces. What you see here is a more complex model that incorporates not just transmission and hospitalization. You still see ICUs and H's here for hospitals and recoveries and death. But you also see we've got a set of V's up top here, which stood for vaccination. We had different types of vaccines that were being deployed in country, as well as the number of doses. Each one vaccine required only 1 dose, and another vaccine required 2 doses, and so on. So we had to model all of that and keep track of the immunity, because once your first wave of COVID happened, when the second wave happened, we found that there was cross immunity to protect people from getting infected severely twice. And so you see 4 arms here. This was to represent at the time 4 variants. So it was a model replicated now for 7 age groups. So imagine this diagram replicated 7 times, replicated again. It's got the 4 variants in here, and then replicated again for 3 risk subpopulations. So this was taking into account healthcare workers, your population with comorbidities, and the general populations, and then multiplied again 9 times over. It gives you a lot of replications for this model. So you can see how complex things had to be to answer the questions that were put to us much later on in the epidemic, especially when variants were abound. So here are some of the outputs that we presented, and you've seen this here with the models, but we have, for example, we were looking here at doing scenario modeling, where we had to show the impact of, you can see several interventions. What would this future scenario result in, where we've got, where your orange here represented hospitalizations over time. So this was just a validation plot to show that we have presented a number of scenarios for this particular province on hospital admissions, and scenario 2 was looking to be the more likely option for what had happened retrospectively, but we were presenting scenario choices at the time. We also had to track the epidemic, and what you see here on the right-hand side is for another district in South Africa, tracking the epidemic over time, where we are reporting, for example, where we're in a post-wave phase, but when the wave, we think a new wave is starting again. So an indicator of a new wave, and then in red here, when you're well into a new wave, and blue is when the wave is over. So we were tracking the epidemic to give some warning to decision makers so that they will be able to plan adequately, with our scenario analysis being maybe a few months ahead as a projection. But these epidemic trackers being really a 2-week or so prediction to help with short-term planning. We also provided estimates here of ICU and non-ICU related deaths. And this was, you can see a map here doing something spatially across the country. We provided another tracker to help with decision making, to be linked with actions that the Department of Health would take, as to depending whether they were in a control phase, an alert phase, or a heavier detailed response phase. So there were several types of outputs that we had to put together. And when you look at it all together, we ended up supporting a number of different types of decisions. So think back to the malaria example, where I was presenting on advocacy and estimating costs and reaching elimination as a goal. Here we were providing policy support. We were estimating for the government things like the number of beds that were needed, the amount of oxygen, ventilators. Do facilities have enough beds, and will expansions be necessary? What about the staff required? If you're going to have X number of hospital beds occupied, do you have enough staff in your facility, or is there some exchange of staff that is going to be required between facilities. We supported throughout the 2 years of the pandemic, we supported the Affordable Medicines Directorate with estimating drug quantities. Now here we're talking about medicine quantities that will be ordered at clinics and hospitals and made available at clinics and hospitals throughout the epidemic. So our projections helped to provide those estimates. We supported the placement of field hospitals, the number and placement of mortuary containers at hospitals, and this was particularly useful at the peak times of the epidemic. But we also supported the budget planning and the macroeconomic impact of the interventions that were and the lockdown levels that were implemented by the South African government, and provided a range of scenario modeling and short-term forecasting. So in these 2 years, what we learned, and I think I've got it up here, is that we learned that modelers, we had to be agile and we had to be adaptable, because the decision makers' needs were key at this point. And your national level decision makers based in a national ministry of health will be different to provincial or admin level 1 decision makers or implementers even at the district level. So depending on the needs and the decisions that need to be made, we have to adjust our modeling and update our models so that we can remain useful. Otherwise, what we would be doing would just be an academic exercise, and that's, academic exercises can be great to support the development of knowledge, but when you in an emergency situation like the pandemic was, there was a need for responsive modeling rather than academic modeling. And I think you can see from the decisions we were supporting how very practical it had to be. What this also meant was that we had to have an open line of communication and to be good communicators of our modeling efforts. We couldn't be there talking with about complex sets of equations and computer code. I don't think any member of the ministry ever saw any lines of code or any equations from us. They only ever saw outputs that would be easily digestible or easily communicated to themselves to be but at the same time, it doesn't mean that we were irresponsible. It means that we had to communicate the assumptions and the limitations of our models without showing off with equations and complex code. So the skill of being a modeler is not just about being able to do the modeling and create fancy plots and write good code. It's also about being a good communicator and being able to get your message and your scientific evidence across to those who need it and can action it. Okay, so that was an example of COVID-19. I'm just looking at the time and I can see that we've probably got about 10 minutes. I'm going to take you quite quickly through the next 2 examples. Here's another different example. It's not a South African example. It's an example of something that was requested by the WHO because it was a model that wasn't in existence, but was needed by the WHO to support LMICs all around the world. And this model here was to estimate the health impact and the cost effectiveness of an introduction of diphtheria, tetanus, and pertussis booster doses in low and middle income countries. So those of you who have children or engage with children a little, especially little babies, often will know that at the early stages of life, sometimes around the 6, 10, and 14-week age of the child, the DTP primary series dose, that's DTP for diphtheria, tetanus, pertussis, these doses are administered to babies. But what has been found over time is that immunity to the vaccines have waned. They are not lifelong protection. So booster doses are necessary, and countries have to make a decision as to what boosters to introduce, because there are a range. There are actually 3 different types of boosters that can be introduced. So countries have to make this decision, and they make these decisions based on the cases averted of these conditions, diphtheria, tetanus, pertussis, as well as on the cost of introducing these vaccines. So again, it became an econ model that had to be developed. But this time, it wasn't just about one disease like malaria or COVID-19. We had to do this for 3 diseases. And so we developed a 3 disease model. It was the first of its kind globally, and this model was for populations that in which diphtheria, tetanus, pertussis were transmitting. It had to be age structures to take into account that these are administered to babies and booster doses at other ages as the children grow. We had to take demographic patterns into account, maternal immunization into account, and then cost all of these cases and hospital stays and so on. And so we had to develop a very novel way of working on such a complex model and then deploying it in an app as was required by the WHO. So we had to create an app, and then you start asking questions like, how can we create an app? And so we decided to use R, because R software is free, and the R Shiny software. I'm sure many of you have developed apps in R Shiny before. There's some code assistants now that are really helpful. We found that R interfaced with R Shiny was a very powerful collaboration to explore to develop our tool. And so I'll give you a very brief, a few screenshots of what the tool looks like. The support was provided by the CDC and the Africa Field Network organization, as well as MASHA, who did the modeling. We've developed this tool that allows you to choose your vaccination, the ages at which your primary series happens for your country. So you can select your country in order to personalize or customize the tool for your country setting, and you can add in some cost information as to how your vaccines are delivered and so on. Here are some of the kind of results that could be outputted. You can explore scenarios such as, here we have a baseline where there are no boosters that have been introduced, but what happens if we introduce an infant booster? And what happens if we introduce an infant, child, and adolescent boosters? And let's look at their impact over time on pertussis, diphtheria, and tetanus. You'll see, for example, with diphtheria, it's very, very low numbers, because unless diphtheria is endemic to you, it's very much an epidemic-prone disease. But it's important to be protected against diphtheria. And what you see at the bottom here is a handy little table working out the cases averted and deaths averted due to each of these strategies. And this helps countries to look at the epidemiological impact, but also the cost. Here we see an example of the net total cost of vaccine introduction and the impact on the budgets for introducing these vaccines. And these are very useful outputs for those in government to make a case for introducing vaccines. So here we find ourselves as mathematical modelers working very closely with economists. And we have piloted this project, or this tool, in Uganda. Uganda was the first country to make use of it. It required a set of workshops with our team to work with the vaccine and the National Immunization Advisory Group specialists in Uganda to use the tool to devise their strategy. And this project is now almost at its conclusion, with the final strategy being deliberated upon through outputs from our tool at the end of the month. So we are very much looking forward to the closure of this project to demonstrate another successful use of this tool. So now I'd like to dwell on two different aspects. I've shown you a couple of examples, and you've seen how the different types of decisions that modeling can support, and you can see how useful it is. But the real question comes down to, how do we accelerate modeling to be used for decision support in the global south? As much as modeling has been around for a long time, it is not widely taken up by our governments. Also because we do not always have African modelers at the beck and call of, or even available to governments to be conducting these studies. And so when you're looking at the system of how to generate a model, you're going to need modelers and you need decision makers to be able to both contribute. So there needs to be both, I would call, demand from the decision maker side and supply side from the modeler side to come together to develop the models, and we find that our decision makers are providing contextual knowledge and data and helping the modelers make better models. And the modelers need to help decision makers to translate this modeling evidence to enable the modeling to support the decisions that need to be made. Just because a model makes a recommendation doesn't mean that's automatically what a decision maker should use. Some translation needs to be effected as well. So how are we at MASHA planning to support both capacity strengthening of modelers and decision makers to enable this synergy and increase in demand and supply to create modeling or to advance modeling on our continent? Well, we are currently hosting a project that is funded by the Gates Foundation, and this is the MALA initiative, Malaria Modeling and Analytics Leaders in Africa initiative. You can see all of us here with our matching hoodies, where we are training approximately 13 PhD modelers from 11 different countries across our African continent. And these students are all learning quantitative skills in modeling. They're learning about malaria policy and implementation, malaria biology, as well as programming. They receive regular training. In fact, they are now in their third year of their PhD and are still receiving training from the programming side and the modeling side, and are having their first publications and advancing quite well in their PhDs. What's important to understand is that their PhDs are done directly with their government. So their national malaria control programs, their governments are partners in their PhDs. So their PhDs are going to have the ability to inform decisions that the governments are making. So each student is doing a PhD on a priority malaria project. At the same time, they're receiving leadership training. So we have scientific communication training on an ongoing basis, stakeholder engagement, and knowledge translation training. And we don't do this alone, we do this with our partners. So we have local partners in the country, advocacy partners from the Southern African region, and operational partners who help us to be that interface between the academic institutions like ourselves and the governments directly. So this is our initiative from MASHA to be growing malaria modeling training on the African continent. So let's look at another bit of capacity strengthening that we are doing, and that is from the modeled evidence point of view. So how do we translate modeling once it has been produced into decisions, and how do we capacitate decision makers to understand or critically engage with modeling? So here, as Nicola had mentioned, I'm the chair of the WHO IVORAC committee. I've put a link here on the presentation should you wish to learn more about this committee. This committee, as part of the WHO, adjudicates on the immunization and vaccine modeling research and implementation research that is being done at a global, national, and regional scale. But we are also doing one activity that from the immunization or vaccine preventable disease perspective it will be targeted directly to global, regional, and country level decision makers. And here we are developing a guidance document for these decision makers on how to actually use modeling evidence to inform strategy, policy, and program decisions. And the guidance document is going to be complemented with a toolkit on how to implement the guidance and provide further support on implementing this guidance, conducting workshops, and that's phase 2 of this engagement. We hope to have this guidance document completed by September this year, and then start a series over the next 2 years of implementation and workshopping this guidance with national advisory committees throughout the globe. And so this helps us to accelerate and helps decision makers to understand modeling and to thereby also increase their appetite for modeling. At the same time, and I don't actually have it on the slide here, we're doing something very similar shortly for Southern African decision makers in malaria, where we are running a malaria modeling translation fellowship that starts in May and extends over the next 6 months for these decision makers. And we have our cohort established already of 20 Ministry of Health officials from 7 countries who will be participating in this fellowship to improve their engagement and understanding of modeling. So in this way, we are trying to improve both the demand and supply side of modeling to increase and advance modeling use on our African continent. Very briefly, I'm just going to put it out there that we also, on the data science side, as I said, I would mention we working in the data science field at the Department of Statistical Sciences at University of Cape Town. With our partners, the Clinton Health Access Initiative, MASHA has orchestrated a data science for health internship program or fellowship program where our master's students who are data science and statistics master's students engage with governments on conducting their master's research on a government problem. So, for example, we've had students developing models to optimize emergency services in some provinces, or to look at the district level prevalence of, estimate district level prevalence of disease, using medicine ordering data where such data are not available, to look at irregular travel patterns of government vehicles towards supporting better efficiency or a gender gap in public sector health employees in an area to, again, assess how we can reduce the gender gap. And so in many ways, we are using different helping master students to analyze government data using various data science, AI and machine learning methods to solve problems of today. And this is a project that could well be replicated in other countries, but would need some leadership from other countries. And we'd be very willing and happy to speak with anyone interested in furthering these types of programs in their countries, so that we can also share some lessons learned from our experience in South Africa. So I want to end off with just a few points for us to think about. The first point is, will we be around for the next pandemic? I think most of us are saying, hopefully not. I think the next question is not about being around to witness it, but being around to support the response. And I should hope that I am not the next person to lead the analysis, as was done for this for COVID-19 for the next time we have a pandemic, because I would hope that we are building, we are expending efforts to support increased capacity development and creating a workforce of modelers on our African continent to take over and be the steady pool of experts who can be called upon to support pandemic response on our African continent. And so we at MASHA are doing what we can to support capacity development, but I believe this is a message that does need to be put out, an investment made on our continent in various aspects of modeling. So capacity building really is essential to leverage and sustain skills over time. At the same time, we also, as I mentioned, communication being so important, we need to keep these pathways to impact open. And by that, I mean academic institutions are quite used to operating in silos, operating academically only, and not having well-established relationships with government departments. And this may have changed during the COVID pandemic, but these pathways to supporting decision-making, they need to be concretized. There needs to be a distinct pipeline that is independent of the people who are currently involved and become available even when the younger workforce takes over. And so this investment is really needed in the skill set of disease modelers, but I'm sure many on the field of you on the call will think about your own fields. In the case of disease modelers and analysts, we really do need modelers who are skilled in systems thinking, mathematics, computer science, statistics, epidemiology, economics, and public health. So I'd like to end off today by thanking you all for listening to my talk, and also to H3D for inviting me. And I'd like to end off with a quote by Dr. Albert Sabin, who is well known for developing the first oral polio vaccine, because he said something that resonates very well with me as a scientist, and I hope it does with you all as scientists too, that a scientist who is also a human being cannot rest while knowledge which might be used to reduce suffering rests on a shelf. And I do hope that today I've been able to inspire you a little to take your science and do what we can to help our science be as impactful as possible, and to reduce global suffering as we all experience it on a daily basis. Thank you once again.
Sheetal, thank you so much for that really, really inspiring presentation. I'm sure we're all feeling we've got more fuel in our tank going forward. I'm going to open up to questions in a moment and unmute our participants. But I'd love to just kickstart the discussion with a question about how do you get into modeling? So it's a two-part question. The first is, if there's anyone who's really inspired and wants to kind of pursue this a little bit further or pivot from their current career path, what is required to get into modeling? And then the second thing is, when did you know that it was the right path for you?
Thank you. So I think the pathways to modeling can be quite different. Some people they are biological graduates, or so BSc graduates who get into modeling. Some are mathematicians. Some are people who come from finance. I myself was studying actuarial science before I came into this field. What you need to have is a love and good understanding of mathematics, and an ability to think of a system. So not just thinking about, oh, I want to model a disease, but to realize that a disease sits within a health system. There is a population who is experiencing this. There is a government who is supporting this. There are funders who are providing another source of support. And so thinking about a whole system, so taking a systems approach, if you are able to think in that way, I think that you would have a much easier inroad into modeling. But that being said, there's not a very clear career pathway. It's usually a postgraduate study that is done, and after that, experience is needed. So working in a research group that has experienced modelers, working as part of projects, will give you that on-site experience to be able for you to lead a project. Because what you need is a skill set of taking real data and a contextual situation, and being able to write a set of mathematical equations and computer code to replicate what is happening in reality, and understand the assumptions that you're making and the limitations. So it's a long pathway to become a modeler, and that's probably the reason why we don't have so many modelers. But getting in, just starting at least from postgraduate, from master's level study, taking a short course, and so those will be really those are good ways just to develop your interest in the field. Actually, just as I'm remembering now, in August we will be running a short course on an introduction to mathematical modeling for health. And I will, Nicola, in the next few days share a link with you. I just need to update the website, and I will share a link with you. If you can perhaps share it with your with our webinar group today, we would welcome participants to that introductory course. And it's a nice way to whet your appetite if you are interested in pursuing modeling.
Sorry, I'm struggling with my microphone there. Thank you. And then the second part to my question, when did it occur to you?
Of course, yeah. So with me, I studied actuarial science, which is quantitative finance. And I did that because at school I was told that if you are good at mathematics and you like problem solving, that is the only pathway for you. So I went and I studied that. I was not thrilled, as in I enjoyed the mathematical and computational aspects, but the idea of working in corporate, it was attractive, being being a finance bro, as one might say, but it wasn't sort of me at the time. And then I learned what operations research was, and operations research was the ability to use your maths to solve problems. And once I did that, I realized, oh, I can use maths for something other than finance. And I suddenly realized I could do this for health. And as soon as I came to that conclusion that I could use my maths to help solve health problems, I stuck in the field. And I did my master's project actually on malaria modeling. And well, I never quite stopped after that.
Thank you. That's fantastic. Yeah, the passion has to be there. Otherwise, it's just not going to work, right?
Yeah,
Okay, if there are
absolutely.
any other questions, feel free to raise your hand. Okay, well, then it just leaves it to me to say a huge thank you to Sheetal. Thank you so much for your time, your passion, your expertise, and for being with us today. We really, really appreciate it. This is going to go onto YouTube, so it'll be reach a wider audience as well. And we do have some shareable slides if anyone needs them in the future. Thank you so much.
Thank you, everybody. Bye-bye.